Dear participants of the Swiss Academy of Ophthalmology, on behalf of our family company Oertli Instruments, I'm welcoming you to our first online feature at this year's Swiss Academy of Ophthalmology. Our topic today, COMICS, Coaxial Microincision Cataract Surgery. Coaxial microincision cataract surgery through incisions as low as 1.6 mm has gained a big momentum recently, as intraocular lenses for such small incisions have become broadly available. One of the first ever coaxial microincision cataract surgeries through an incision of just 1.6 mm was performed by Professor Rupert Menapace from Vienna with a specifically designed phaco tip by Oertli. That was the birth of the COMICS tip. Since then, Oertli has further developed and improved the technology significantly. Today, with the latest easyTip COMICS, you can easily perform cataract surgery through incision sizes as low as 1.6 mm. COMICS surgery, in our view, not only helps reducing astigmatism, it also can support recovery and comfort of the patient postoperatively. And of course, the incision is very easy to perform. Thanks to the specific design of the COMICS tip, your 1.6 mm phaco surgery can be performed as comfortable as through a standard 2.2 or 2.4 mm opening. The Oertli COMICS tip has an extra large opening for strong holdability of the lens fragments. This allows efficient application for ultrasound, and the slim shaft helps to prevent any surge upon occlusion break. The large infusion mantle around the tip makes sure that there is enough irrigation into the eye, keeping your anterior chamber stable even when working with high settings on your machine. Our guest today, Professor Daniel Mojon from the Eye Surgery Center St. Gallen, is a strong advocate for coaxial sub 2 mm surgery. He has performed thousands of COMICS surgeries up to today and developed his own surgical technique, which he is going to share with us today. We are happy to join him together in his OR to learn more about his approach and his technique and how cataract surgery through an incision of just 1.6 mm benefits him and his patients. Let's join in. Daniel, thank you for having us here at your eye surgery in St. Gallen.
You're very welcome.
Thank you,
Thomas.
I was already able to give our viewers a brief introduction into our COMICS technology and how it is performed, how it has evolved, how it works. Now, you have performed already more than 5,000 COMICS procedures. And of course, we are very curious about your technology and how you are performing COMICS surgery. So within the next few minutes together with you, what can we expect from you? What are you going to show us?
Well, we are going to show you that COMICS is even safer than performing a larger incision cataract surgery. The anterior chamber is more stable and the surgeon is performing more safely surgery because there is more space in the anterior chamber, especially if you have a shallow anterior chamber like in a hyperopic patient. What I cannot show is my transition I did many years ago. When I started, I was afraid that it would be too difficult to do. And after 3 months, without having any complication, I had to slow down a little bit surgery. I realized that I was where I ended with the 2.2 incision size. And 3 months later, meaning 6 months after starting with 1.6 millimeter COMICS, I realized that I felt much more safer during surgery. This was for me an absolutely great experience to see that making incisions smaller even makes surgery safer.
When we now go together into the OR, is there anything particular you want the viewers to focusing on?
Well, first of all, we will talk about the relationship between the incision size and the wound size. This will be something very important to understand because many colleagues say, well, doesn't matter, stepping down from 2.2 to 1.6 is not really important. We'll see the difference in the operating theater. And this comics also allowed me to develop a new technique 2 years ago. I called it VIP, viscoelastic irrigation pressurized surgery, because I like to have the eye pressurized during surgery to avoid a postoperative posterior vitreous detachment, and also to avoid a hypotony that might lead to a potential vision-threatening bleeding. And you will see as well this technique. I will explain you how it's easily done without using an anterior chamber maintainer.
Oh, that's wonderful. I would say let's go and scrub in.
Let's go and have a look.
Let's go.
I'm Daniel Mojon. I'm showing you a microincision cataract surgery with the Oertli comics technique and my personal technique called VIP viscoelastic irrigation pressurized surgery. First, I will show you the incision size. On the left, you will see a 2.4 millimeter knife. On the right, a microincisional comics knife 1.6 millimeters. Okay, perfect. So the wound size, because it's a square, will be less than half when you use a 1.6 instead of a 2.4 millimeter incision. So wound healing will be much faster, and there is no need to close the eye anymore after surgery, with a lot of advantages. We will talk about that later on. Excellent. Like this is perfect. Now we nicely see that the incision is a square. Now we make the side incisions here for irrigation, aspiration, and manipulating the nucleus while performing surgery, and capsulorhexis. Now we do a hydrodissection to prepare nucleus manipulation. And now this is the comics Oertli tip 1.6 millimeter. The whole irrigation is performed through the Phacoemulsification tip. There is no need for an additional irrigation using the chopper. So the chopper is a Nagahara chopper here. It's my favorite. Sometimes in very soft cataracts I'll take maybe another one, but for the majority of cataracts this is a very nice chopper. Quite soft nucleus. I think it's so soft that I can go without chopping a lot. I will immediately take out the majority of the nucleus. The anterior chamber is very stable, no problems, having only a small incision size. Can even do very hard nuclei. I personally prefer the 45-degree tip because it's just more surface area that allows you to have a higher energy. It's 53 degrees. Okay. Well, this is Swiss precision. It's 53 degrees and not a tenth of degree more or less, you know. And now I'll show you the VIP technique. Now I go in with viscoelastics and I fill the capsular bag into the anterior chamber before I retrieve the Phaco trip. Thus, I'm not allowing the anterior chamber to collapse, meaning that we have less anterior movements of the vitreous body, leading to less postoperative posterior vitreous detachment, and we know people might then see floaters or even get more serious problems like Irving gas, macular edema, or even retinal detachment. So especially in very highly myopic eyes or in eyes that have already a maculopathy, this viscoelastic irrigation technique is even more helpful. Now again, I'll go on the other side to switch irrigation and aspiration. Again, I go in with the viscoelastic and I go out with the irrigation cannula, not before I have stabilized the anterior chamber. Now we are done. This little opacification there is not really, I'm not able to take it out. Now, as you can see, there are lenses that can really be shooted without any problem. They can be toric, they can be multifocal. As you can see, this is a very nice lens. I like very much this haptics, but sometimes I also put the C-loops haptics inside. And now, again, important is we have really here now to close while we stay in with the irrigation cannula for the VIP technique. We need to really hydrate the openings to be sure that they are really nicely closed. Now, before I go out here, you will see that I hydrate this opening as well. You see now it gets hydrated. And now I stop and immediately go in to hydrate more because I want to avoid any movement anteriorly of the iris lens diaphragm. Now we were able to perform cataract surgery through a Comix 1.6 millimeter opening. You see how small the wound is. You see the nice centered lens, and we never had a anterior movement of the lens iris diaphragm. So we close now your left eye. We are not doing that anymore, just to show what the difference is. If a patient goes home like this, if I put my fingers here and you look at my nose and you tell me where do I move the fingers?
On the left side.
Yeah, and now where do I move?
On the left side.
Exactly. So you're not able to see.
No, I don't see
when,
it.
when do you see it on the right?
Now.
Yeah. So
the halves.
we see it's about even more than 30 degrees that the patient has no peripheral vision. If he goes home like this, there is really in the traffic, maybe you're not allowed to drive, but if you walk home, this is really something important. that you're having now for maybe 24 hours, no peripheral vision. Now, the other important thing is that you have no stereo vision. Now we'll show quickly, if you take that from the side quickly, try to take it with your hand from the side. Yeah, again, do that as quickly as you can.
Well.
Okay, again. So you have seen you missed that. And now if after surgery, because we did a Comix 1.6 millimeter Oertli small incision, we don't need any more the bandage, you can put that away. And now, how is your feeling about taking that? Take it again very quickly. Maybe just with one hand. Again.
It's perfect.
Yeah, and now you see you can grasp that, do it again without any problem. If this eye is closed, do that again. Here maybe it works, but here, yeah, you see already it's not working. And the other important thing here is, now peripheral vision is normal. Where do I move?
Both hands.
Both hands. So now peripheral vision is 180 degrees. And so this is safety for the patient. I think this is very important. And now you had surgery in another place on your right eye, and they closed the eye, I think for a day, and during the night you had them for a week usually to cover the eye.
Exactly.
How is your feeling now? How is your vision already? What do you have the impression? Is it already better than before surgery?
It's much better.
It's already much better. So that is another thing. Using a small incision cataract surgery and also the VIP stabilization technique, usually patients who have a cataract that has a certain strength, they really see better immediately after surgery. So surgery was like 5 minutes ago, the end, and you already see much better than before surgery, because the cornea is also always held in the physiologic curvature, and we don't have any intraocular pressure drop to zero. So also the endothelial function is much better directly after surgery, and we have less Descemet's fold after surgery using this stabilization technique, and together with this great 1.6 millimeter Comix technique from Oertli.
Daniel, that was very interesting we do in the OR. Now, before we jump into the discussion with our viewers, I ask you again, what are the most important bullet points you want our viewers to take home with from today's presentation?
The most important points are, if you reduce incision starting doing Comix, you reduce the induced astigmatism. This is very important for refractive cataract surgery. Then you're avoiding patching the eye, meaning that the patient has a larger peripheral visual field and he has stereo vision, as we have seen before. And by not patching the eye, the temperature in the anterior chamber will not rise by 10 degrees, with a huge increase of endophthalmitis, because we always have bacteria in the anterior chamber at the end of surgery. And patching really is something I don't want to do. For the VIP technique, don't forget, without an anterior chamber maintainer, you are able, with the material you're having in the operating theater, no need for an additional opening, no additional liquids, to pressurize the eye during the whole procedure. The two things are really like fitting very well together, the small incisions and the VIP technique. The VIP technique has the advantage to reduce the postoperative induced posterior vitreous detachment, is increasing the direct postoperative visual acuity, and is also pressurizing the eye and avoiding intraocular expulsive or other types of bleeding.
I know you have a wonderful hobby. You are very much into astronomy. Now, for once,
correct.
instead of guessing into the stars, let's guessing into the future of ophthalmology. What would you wish, or what do you believe would be great for ophthalmic surgery in the future?
Customized printable lenses. The patient shows up, we measure everything, we print the lens, and we implant it right away. That's it.
That sounds very interesting. Daniel, thank you very much on behalf of Oertli and all my team. Thank you for staying with us or being with us in that show today. And we are looking forward to seeing you right away live in our questionnaire. Thank you very much.